Good evening, everyone. Welcome to Unacademy, where you can crack all NEET PG exams with us, with our top educators, quality content, and have a great learning experience here. So, guys, let's crack NEET PG. I'm sorry for the slight delay. There were some technical issues with my laptops, hence there was a slight delay. I'm so sorry. A little about me. I've done my MBBS from Father Muller Medical College, Mangalore, and my MD in Anesthesia from Father Muller Medical College, Mangalore itself. I have two publications and one paper presentation in the field of anesthesia, and I've been working and teaching in Bangalore for the past 2.5 years. So, guys, let's crack NEET PG. With today's topic, that is the reversal of neuromuscular blockade. I have covered till now, we have done the neuromuscular blocking drugs, that is your depolarizing and non-depolarizing agents in detail. We have completed neuromuscular monitoring yesterday, and today I will be dealing with the reversal of neuromuscular blockade. So basically, we have administered the neuromuscular blocking drug. The patient is paralyzed. We have monitored the depth of this paralysis, and now we need to know when we need to reverse this paralysis with these reversal agents, so that we can get the patient's muscle back to the normal resting condition prior what it was prior to anesthesia administration. So guys, let's crack NEET PG with India's largest learning platform, which is Unacademy. You can get plus subscription and access unlimited live and recorded courses from India's best educators. So guys, don't delay, get your subscription, start preparing for NEET right now. Let us help you prepare. We have our YouTube platform, special class platform, our subscription platform. Do access our special class platform too. It's really good. And guys, subscribe. I will be telling you all why you all should subscribe. So guys, hurry. What do you get out of Unacademy? So you have your daily life classes where you can chat with your educator, engage in discussions, clear your doubts, and answer polls, all while the class is ongoing. So basically, when you go to a coaching institute, like I keep saying, it's first of all time consuming, because you have to travel to get to a particular destination. Okay, sometimes you might be staying close by, but still, the whole concept of you getting ready, traveling, there is wastage of energy and time. Also, time is very precious in when you are preparing. You have to make the maximum use of whatever time you have, plus along with rest. You cannot overdo it, otherwise your retaining capacity, I'm sorry, will decrease. So maximum utilization of time as well as time for relaxation has to be there. So when you go to your coaching classes, you sit in your coaching class, you cannot, there are so many students in a class, it's very difficult for the educator over there to clear everyone's doubts. So your doubts might not be cleared, you might not get a correct place in class, you might be right at the back. If you're late, you'll miss a class. So over here, during the live classes, you can engage in your discussion, you can engage with the educator. It's almost like a one-on-one. As the classes are going on, we clear your doubts. That's on your special platform. We can clear your doubts as the classes are going on during your subscription platform too. These are structured courses, all that are in line with the exam syllabus, so that we can help you best prepare for them. It's all research, and the courses up and quizzes and tests are prepared in a structured manner. You have your live tests and quizzes where you can evaluate your preparation with our regular mock tests, quizzes, and get a detailed analysis of your performance. Of course, you have unlimited access. One subscription gets you access to all our live and recorded courses, where you can watch from the comfort of your devices and the comfort of wherever you are. So it is just one subscription, and you can sit at home or wherever you are at your own. I mean, according to the time of the class, you can they are prepared for you in a structured manner. You can take your class from your device. So it is very helpful whether you are traveling or wherever you are able to take your class. These are some of our top educators on the platform, as I'm pretty sure you all know by now. Dr. Nikita Nanwani, Mohammad Azam, Divesh Mishra, and Dr. Preeti Sharma. We have 19 courses that are offered to you all that you all can prepare from, and various 19 subjects and various courses in each subject, as you can see, prepare from. These are some of the ongoing courses on our platform. Like you can see, neurophysiology, course on GI surgery, cardiovascular thoracic surgery, pathology, respiratory system, and a course on larynx. So now guys, coming to the subscription part. So as you can see, there are 5 types of subscriptions. I would suggest that you all, frankly suggest that you all go for the 12 and the 24-month subscriptions, because I'll tell you why. So you up, like I previously told you, 19 subjects. You all are preparing for NEET PG. It's not easy. You all have to complete 19 subjects. These are not small subjects. These are large subjects. The content in these subjects is vast. So you all need to cover those subjects. And 3 and 6 months is really not enough. I mean, it's not very practical to cover these subjects in depth in these months. So your 12 and your 24-month, you can do it in a structured manner, because we are preparing you in a structured manner. So with your 12 and your 24 months, you can take your time, you can clear your finish your preparations and give your exams for more results. And so with your 12 months also, it is more economical because it's a one-time subscription. So after 6 months, if you want to fall back, take a test, if you want to revise a class or clear your doubts, you have to subscribe again. But with your 12 months, it's one subscription covered for the entire year. So guys, please use my code, as you can see at the bottom of the screen, written in red, SASHA, and you'll get a 10% discount. So guys, subscribe, start preparing, let us help you prepare for NEET PG. Like I explained, the 24 months, not everyone again can clear in 12 months. If you want to give yourself time for that 24 months, yes, it's one-time subscription covered for 2 years. So guys, please subscribe, use my code SASHA. Again, you can avail a 10% discount. So hurry, let us help you at Unacademy. So coming to today's topic, which is anticholinesterase. So these are basically your reversal agents which we use to reverse the neuromuscular blockade. Okay, so now anticholinesterases, anticholinesterases basically inhibit the action of acetylcholine esterases at the neuromuscular junction. Now what is the acetylcholine esterase? Acetylcholine esterase clears acetylcholine from the neuromuscular junction. Now this is how the action of acetylcholine is terminated, because acetylcholine is degraded by acetylcholine esterases, and hence it diffuses away from the receptor, and the muscle is allowed to repolarize and come back to the resting phase. So anticholinesterases inhibit the action of acetylcholine esterases. So there is more acetylcholine, because acetylcholine is not being degraded by acetylcholine. So there is more acetylcholine at the neuromuscular junction, which will lead to your contraction. So basically your neuromuscular blocking drugs, basically this is given for your non-depolarizing. Okay. That is your vecuronium, atracurium, pancuronium, your non-depolarizing drugs. They are competitive inhibitors, like I have told you all previously. That is, they compete with acetylcholine at the neuromuscular junction to bind to the acetylcholine receptor. So when these competitive inhibitors, these non-depolarizing muscle relaxants bind to the acetylcholine receptors, they block the receptor, and there is there is no contraction occurring. So when this acetylcholine esterase is inhibited by this anticholinesterase, more acetylcholine will be present at the neuromuscular junction. As a result, it will compete. More acetylcholine means, and less non-depolarizing means, this non-depolarizing will diffuse away, and acetylcholine, because it is a competitive inhibitor, it will bind to the acetylcholine receptors and reverse the blockade, that is lead back to muscle contraction. So thus prolonging the half-life of acetylcholine and potentiating its effect, especially in the presence of residual amounts of non-depolarizing relaxant at the end of the surgery, like I just said. Hence, inhibition of acetylcholine esterase at the neuromuscular junction will prolong the half-life of acetylcholine, because acetylcholine will not be degraded by acetylcholine esterase, and this will potentiate its effect at the neuromuscular junction. This especially occurs when there is, so non-depolarizing muscle relaxants after a particular duration of time are automatically degraded, right? But any residual amounts will be reversed, any residual amount of paralysis will be reversed because of this anticholinesterase. Now, the primary clinical use of cholinesterase inhibitors, also called as anticholinesterases, is reversal of non-depolarizing muscle blockade. It is not, so succinylcholine cannot, that is your depolarizing muscle relaxant, cannot be reversed by this, because your depolarizing muscle relaxant is degraded by butyrylcholine esterase or plasma choline esterase, that is synthesized by the liver, okay, by this enzyme butyrylcholine esterase, right? So some of these agents are also used to diagnose and treat myasthenia gravis. So this is, I will be dealing with this on my class in myasthenia gravis, but this is also one of the uses of anticholinesterase or cholinesterase inhibitor. So one is to reverse non-depolarizing muscle blockade, and the second is to treat, diagnose and the treatment of myasthenia gravis. Now, goals of reversal of neuromuscular blockade. So the primary goal, why do we need to reverse this neuromuscular blockade? So the primary goal is to maximize nicotinic transmission with the minimum muscarinic side effects, right? That is the goal, that is nicotinic transmission. So these anticholinesterases, when they bind, they cause they inhibit acetylcholinesterase. So there is increased acetylcholine. This acetylcholine can also bind to the muscarinic receptors, and this binding, it can cause a lot of side effects like increased secretions from the various glands, vomiting. So because of this, because of increased, so the main goal is we need to promote neuromuscular transmission, nicotinic action, not the muscarinic side effects. So that is the goal. How to and how this is accomplished, I shall be telling you shortly. Reversal of blockade. So we want to reverse the block and get the muscle back to the normal depolarizing muscle. We need to get the muscle contractions back. We need a spontaneous reversal. There should be no residual paralysis. There should be redistribution, metabolism, excretion from the body, and pharmacological reversal. So these are the goals. So there should be redistribution of the muscle relaxant, there should be metabolism of the muscle relaxant, excretion from the body, along with pharmacological reversal. So cholinesterases indirectly increase the amount of acetylcholine available to compete with the non-depolarizing agent, thereby establishing normal neuromuscular transmission, as I explained. Now, cholinesterase inhibitors can act at the cholinergic receptors of several other organ systems. That is, they can act at the various muscarinic receptors, like I said. So, cholinesterase inhibitors, they can act because acetylcholine is free. There is a lot of acetylcholine, so it will bind to the muscarinic receptors. So, it can produce a lot of these side effects. Okay. These side effects are counteracted with your anticholinergics. So, when we reverse a patient, along with these cholinesterase inhibitors, even an anticholinergic like your atropine and glycopyrrolate is also given. What are your cholinesterase inhibitors? Basically, neostigmine, edrophonium, and your pyridostigmine. Yeah. So pyridostigmine, neostigmine, and your edrophonium. So these are your cholinesterase inhibitors. So they can act at the cholinergic receptors at various organ systems, leading to these, what I shall be telling you all shortly, various side effects. These are counteracted by anticholinergic drugs like glycopyrrolate and atropine. Okay. So now, so along basically neostigmine is the agent that is used for reversal. I shall tell you why these two are not used when I come to it. But for reversal of neuromuscular blockade, neostigmine along with glycopyrrolate is used. So we give both these drugs for reversal of neuromuscular blockade drugs. So why do we give this? To count glycopyrrolate to counteract the muscarinic side effects of cholinesterase inhibitors. So the predominant cardiovascular, when they bind to these cholinesterase inhibitors, acetylcholine binding to the cardiovascular receptors, the predominant muscarinic effect on the heart is bradycardia and sinus arrest. Whereas this counteracts, and glycopyrrolate causes increase in the heart rate. At the pulmonary receptors, muscarinic stimulation can result in bronchospasm and increased respiratory tract secretions. So, these increase secretions and they can cause bradycardia. This cholinesterase inhibitors because of the muscarinic effects of acetylcholine. This is counteracted by a glycopyrrolate and atropine because they decrease secretions as well as increase the heart rate. Now your cerebral receptors, physostigmine is a cholinesterase inhibitor that crosses the blood-brain barrier and can cause diffuse activation on the EEG by stimulating basically causing seizures by stimulating the muscarinic and nicotinic receptors within the central nervous system. Hence, physostigmine is not used because it can cross the blood-brain barrier. So, we do not want any drug crossing the blood-brain barrier and activating the binding to the muscarinic receptors and nicotinic receptors in the brain. Hence, physostigmine is not used. Unlike physostigmine, cholinesterase inhibitors that are usually used to reverse neuromuscular blockade do not cross the blood-brain barrier. So this is the reason why physostigmine is not used, because it crosses the blood-brain barrier. Now, at the gastrointestinal receptors, muscarinic stimulation, it increases peristaltic activity. That is, it increases your esophageal, gastric and intestinal, and it can increase your glandular secretions like salivary. This can lead to your post-operative nausea, vomiting and fecal incontinence because there is increased peristaltic activity. This is all counteracted by your glycopyrrolate and atropine. Like I said, your unwanted muscarinic side effects are minimized prior to the administration of anticholinergic medications using atropine sulfate and glycopyrrolate. Glycopyrrolate is what is used. Atropine again crosses the blood-brain barrier. Hence, atropine is not the drug of choice. We use glycopyrrolate, and studies have shown that with neostigmine and glycopyrrolate have a similar onset of action. The time of onset of action is very similar. Though atropine is faster acting, within 1 minute atropine starts acting. Glycopyrrolate takes about 2 to 3 minutes for onset of action. So neostigmine also takes 2 to 3 minutes for onset of action. So they have a similar onset time, hence they are used in combination. If glycopyrrolate, the duration of action is the same for both the drugs, that is around 30 minutes. That is for glycopyrrolate and atropine. So if atropine is given with neostigmine, studies have shown that it is not that useful with the neostigmine, and the termination of action is before it terminates earlier. So there is still that margin is not there. But here the same onset of action, the time of onset of action is similar, and studies have shown this glycopyrrolate is very effective with neostigmine. Atropine sulfate is can generally with pyridostigmine because I'm sorry, with the not pyridostigmine, with edrophonium. Edrophonium is also short acting, and hence the duration of action is it is rapid and short acting. So edrophonium and atropine sulfate, they are studies have shown that they have been useful together, but generally our combination is neostigmine and glycopyrrolate. Now clearance of these drugs is by hepatic metabolism 25 to 50% and renal excretion 50 to 75%. So basically it is more by renal excretion, right? Any prolongation of the action of non-depolarizing muscle relaxants from renal or hepatic insufficiency will be accompanied by increased duration of action of a cholinesterase inhibitor. So it prevents recurrization. That is, recurrization is persistent action of neuromuscular blocking drug after action of neostigmine has, basically of cholinesterase inhibitor has worn off. Okay, so that is recurrization. Okay, so even though the action of this neostigmine has worn off, the persistence of action of neuromuscular blocking drug will be there. So in these patients with renal or hepatic insufficiency, the primary route of elimination of the non-depolarizing neuromuscular blocking drugs is from renal and is through the kidney and the liver. So when there is impairment, there will be prolongation of action. So this prolongation of action of the non-depolarizing muscle relaxant is accompanied by the prolongation of action of the cholinesterase inhibitor. So you will not see recurization. So these are some of the muscarinic effects. As you can see, cholinergic actions. On the eye, there will be miosis, binding to the M3 receptors, contraction of the ciliary muscles for near vision, and there will be decrease in the intraocular pressure. Heart rate, binding of M2 receptors causes bradycardia. Then it causes bronchospasm by binding to M3 receptors, increased peristalsis and secretions. Increased gastric motility and increased secretions predisposing to nausea, vomiting, and defecation because of and urination because of sphincter relaxation. Urinary bladder, there will be contraction of the muscles and relaxation of the sphincter. Exocrine glands, there will be increased sweat, saliva, lacrimal, bronchointestinal secretion. So basically increased saliva, chance of aspiration because the patient is still recovering from neuromuscular block. So he is still under anesthesia. So too much of if the secretions block the air, the chance of aspiration is there. But this is all counteracted by your anticholinergic drugs, that is your glycopyrrolate and atropine. So now coming to when should a reversal agent be given. Now this we have to correlate to neuromuscular monitoring and the duration of action of your neuromuscular blocking drugs. So no amount of cholinesterase inhibitor can immediately reverse a block that is so intense that there is no response to tetanic peripheral nerve stimulation. So when there is an intense block, okay, when there is an intense block, that is, there will be no response to your TOF. This I dealt with in my previous class, that is neuromuscular stimulation that produces a response. So basically neuromuscular monitors are used, your quantitative and your qualitative monitors. Peripheral nerve stimulator is a qualitative monitor and acceleromyography is a quantitative monitor. So when that is used, your TOF is basically represents fade, that is a peripheral nerve will be stimulated and the response of the nerve is recorded on the peripheral nerve stimulator. If there is with the non-depolarizing muscle relaxants, a fade will be seen like this. Okay, a decreasing trend. The presence of fade means there is still some residual neuromuscular blockade. All the responses should be equal to know that there is recovery of neuromuscular blockade. But when there is a response, so initially there will be no response. 0.1 TOF is basically the ratio of the fourth response by the ratio of the first response, right? So when there's a ratio of 0.1, that is there is only one. This is a very intense, this is a deep block, but these are seen with surgical blockades, right? There is a response, but with the when there is an intense block, a very deep block, when the patient is when all the neuromuscular receptors have been occupied, enough number have been occupied by the non-depolarizing muscle relaxants, you will not see this TOF. There will be no, so higher than, there will be no post tetanic stimulation. So your post-tetanic stimulation is seen even when TOF is not present, right, in a deep block. But in an intense block, there will be no TOF, there will be no post-tetanic stimulation. At this point, however much of an inhibitor you give, it cannot reverse a block. There is no point of giving a cholinesterase inhibitor. The absence of any palpable twitches. So when a nerve is stimulated, when you palpate twitches, following a tetanic stimulation. So tetanic stimulation is given in 50 Hertz over 5 seconds. This implies that it is an intense block. So one is you can observe it on the monitor or you can palpate the twitches, and if there are no twitches, it is an intense block and you cannot administer cholinesterase inhibitors. Some evidence of spontaneous recovery, that is the first twitch of the train of 4, should be present before a reversal is attempted. Ideally, 2 to 3 twitches should be present. So basically, like I said, your TOF ratio is your the fourth stimulus by the first stimulus. So this is when your TOF is 1, a single. This you cannot reverse, the TOF ratio is 1. When your TOF ratio is 2 to 3, that time you can think of reversal, okay? But for extubation, there should be no fade in response and your TOF ratio should be ideally 0.9. So reversal agent can be given at a TOF ratio of 2 to 3, but you have to wait for about 15 to 30 minutes before the TOF ratio comes to 0.9, and that is when you can take out the tube from the trachea, that is extubation. Your post-tetanic count, that is the number of palpable twitches after tetanus. So at a tetanic stimulation, that is when a 50 Hz stimulation is applied, there will be no response, okay? Because acetylcholine receptor, there will be no response because acetylcholine receptors are blocked. But post-tetanic stimulation, sometimes a uh, post-tetanic stimulation is seen. That is, after your tetanic stimulation, some palpable twitches. This generally correlates with the time of return of the first twitch of TOF. Yeah. So when you have these post-tetanic counts, so there will be a tetanic stimulus following the, during which there will be no response. Following this, you will see a response. Right. This correlates with your TOF. So when there is one post-tetanic count, it is a deep block. You will not see TOF. Right. When there is 1 and 3, I'm sorry, but when there are 8, that is 8 post-tetanic counts, that is you can feel soon after your tetanus, when you can palpable twitches, it corresponds approximately to a TOF count of 1. That's when you know that, okay, fine, there is some recovery occurring. So PTC of 1 and 3 is a very deep block. You will not get a TOF of, you will not get any TOF response. So when you're putting the mode PTC, if you're getting 1 and 3 palpable, because in PTC the stimulus delivered is very high, so you might get 1 and 3 response, but 1 or 3 palpable twitches, but that indicates a deep blockade, right? But when you get 8 palpable twitches, that indicates around a TOF of 1. That is, there is TOF is returning, and therefore the ability to reverse intense paralysis is coming into play. Now, the factors which affect the time required to fully reverse a non-depolarizing muscle blockade. So the factors which determine it are the choice of cholinesterase inhibitor administered. So basically, when do we need to fully reverse a non-depolarizing block? So it depends on the choice of cholinesterase inhibitor. That is your long-acting or your short-acting or intermediate. So long-acting is your which the onset, it takes time, is your pyridostigmine, neostigmine is moderate, and adrophonium is rapid acting. So basically pyridostigmine is not used because it takes time to come into play. Your adrophonium is not used because it is short acting, it diffuses away. I will explain why. So the choice of drug is your neostigmine. Pyrido is long acting, is takes time for onset. And your adrophonium is short acting. So the choice of agent is your neostigmine. Now the dose, depending on the dose of cholinesterase inhibitor administered, this depends on the degree of blockade as seen by the neuromuscular monitor, and the muscle relaxant being antagonized, and the extent of blockade before reversal, which is gauged by your neuromuscular blockers. So this is your acetylcholine esterase basically. The acetylcholine esterase binds, it has two sites, that is your anionic site and your esteric site. So your anionic site binds by electrostatic forces. It binds to the quaternary amine of acetylcholine. It forms electrostatic bonds, and here by the esteric site it binds to the ester part of acetylcholine esterase by covalent bonds, thus breaking down acetylcholine into acetic acid and choline. Okay, so the esteric site and the anionic site. So the anionic site forms electrostatic attraction with the quaternary ammonium compound of acetylcholine, and the esteric site binds by covalent bonds to the ester of acetylcholine. So how does neostigmine act? So the physical structure of neostigmine consists of a carbamate moiety that provides the covalent bonding to acetylcholine esterase. So it binds to both the anionic site as well as the esteritic site. Yeah, so it binds here by electrostatic bonds, and over here it at the anionic the esteritic site, it with the carbamate moiety it forms a covalent bond. Yeah, because it has a quaternary ammonium group, so it can bind to the electrostatic site. So because of this covalent bond binding, the enzyme as well as the enzyme is inactivated and degraded. Okay, the enzyme is inactivated as well as degraded by this binding. So the quaternary ammonium group renders the molecule lipid insoluble so that it cannot pass through the blood-brain barrier, whereas your physostigmine passes the blood-brain barrier. But so this quaternary ammonium group makes the molecule lipid insoluble, hence it cannot pass through the blood-brain barrier. The dosage is usually 0.04 to 0.08. We use a dose of 0.05 generally, in combination with the atropine 0.02 or glycopyrrolate. Ideally, glycopyrrolate 0.01, right? So 0.04 to 0.08 and 0.04 to 0.08 neostigmine, and glycopyrrolate is 0.01. Okay, right. Okay. So, like I said previously, it takes at least 2 minutes to have an initial effect, and recovery takes around 30 minutes. So, it takes around 2 minutes for your initial recovery. So, this glycopyrrolate onset of action is also 2 minutes. So, since they have a similar onset of action, similar time to onset of action, these two drugs are administered together. Studies have shown this is the most effective combination. So the onset time is 1 minute or 5 minutes. Peak is 10 minutes. The duration of action is 20 to 30 minutes, or more. It can last more than 1 hour too. Neostigmine is metabolized by the plasma esterases, and 60% of the drug is excreted in the urine into the kidney. So like I said, in the presence of renal impairment, plasma clearance is reduced and elimination is half-life is prolonged, and hence this prevents recurrentization, like I explained earlier. Now now neostigmine, edrophonium, and now why can't edrophonium, now I've told you just now about the covalent, I'm sorry, yeah, about this anionic and the esteric site, right? So neostigmine forms a covalent uh, bond here, right? Neostigmine forms a covalent bond over here, but edrophonium forms a non-covalent bond at the esteric site. Hence, the enzyme undergoes inactivation but no degradation. And hence, it is not a permanent binding. Edrophonium diffuses away, and hence it is short acting because it does not form that covalent bond. It does not inactivate the enzyme. Enzyme does not undergo degradation, and hence edrophonium diffuses away. Now, the ceiling effect that is seen with these cholinesterase inhibitors. So, the ceiling effect is as the concentration of acetylcholine increases at the neuromuscular junction, some of the neurotransmitter diffuses away from the neuromuscular junction, undergoes reuptake into the motor nerve terminal. So there is the acetylcholinesterase is inhibited. There is a lot of constant production of acetylcholine. So some of the acetylcholine undergoes reuptake into the nerve terminal. It diffuses back into the nerve terminal. So as this diffusion and reuptake each reach equilibrium with the augmented release, uh, with the increased release of acetylcholine, a peak level is reached. Okay, so one peak level of acetylcholine will be reached. So as diffusion and reuptake is occurring with along with the acetylcholine release, because of the enzyme inhibition, a peak level will be reached. So administration of any additional neostigmin will not increase acetylcholines or reverse the blockade after this. So basically a peak level is reached, equilibrium is reached between the uptake and the release, because there is, it cannot be a cyclic process. There will uptake and then release, uptake and release. So one equilibrium will be reached. This will be the peak level, and any amount of neostigmin after this will not increase your acetylcholine levels and will not reverse your blockage. You cannot go on giving doses of this cholinesterase inhibitors because of this ceiling effect. Hence, blockade cannot be reversed if high concentrations of neuromuscular blocking drugs are present at the neuromuscular junction. So, if there is an intense block, you give a certain dose, the highest dose of neostigmin, that is your 70 microgram per kg of neostigmin. It will cause acetylcholine release, there will be uptake, but an equilibrium will be reached. But any further doses after that, there will be no increased release of acetylcholine. That is, the ceiling effect is reached, and whatever neuromuscular blocking action is happening will continue to happen. So whatever is reversed by what you have given initially will be okay. But this is an intense block. A lot of receptors are occupied, right? And we cannot give that much of drug to reverse all those receptors. Hence, when an intense block is present, you cannot reverse the block. You have to wait for the block intensity to decrease. Hence, we use neuromuscular monitoring. When the intensity of the block decreases as per the monitor, neuromuscular monitor, that's when the reversal agent is given. So, edrophonium, it is 10% less than 10%, potency is less than that of neostigmin. It competes with acetylcholine and binds by a non-covalent bond to acetylcholine esterase at the anionic site. So it forms a non-covalent bond. Edrophonium dose is 0.5 to 1 milligram per kg. Onset time is, this is a rapid onset time within 1 to 2 minutes. Neostigmin takes about 2 to 3 minutes. Neostigmin and pyridostigmin. The effect is about around 2-minute duration of action up to maximum of 10 minutes. So it is short acting. Hence it is not used. Higher doses prolong the duration of action more than 1 hour. So the higher dose, that is 1.5 milligram per kg, that is the maximum dose. It can prolong the block for 1 hour. That is almost as much as neostigmin. So a higher dose of edrophonium is equivalent to a normal dose of neostigmin. Also, glycopyrrolate can also be given. It should be given several minutes prior to edrophonium to avoid the possibility of bradycardia. So the onset of action of edrophonium is within 1 to 2 minutes. Glycopyrrolate takes about 2 to 3 minutes to act. So it has to be given 2 to 3 minutes before this edrophonium, because otherwise bradycardia will manifest. So what are the factors determining the adequacy of recovery? Okay, how do you know that adequate recovery has occurred? Like I said, TOF count at the time of reversal. The time needed to reach a TOF count of 0.9 after reversal administration is shorter when a higher TOF count is present at reversal. So when you are before reversal of a patient, a train of force stimulation is done. So suppose if your train of force stimulation is around 0.4, okay, when you plan to administer, that is the ideal time to administer the reversal agent, you have to wait for about 15 minutes to about 20 minutes before your TOF count, the train of stimulation becomes 0.9, and you can extubate the patient. That is, the patient is adequately recovered, so you can extubate the patient. But if your TOF count is around 0.2, okay, it will take, never know, 45 minutes to 1 hour before your TOF count comes to 9 and you can extubate the patient. Now your time interval between anticholinesterase administration and extubation. Like I said previously, if 4 responsive to TOF nerve are present, generally 15 minutes are needed for a are needed to reach a TOF ratio of 0.9. Hence, that is why anticholinesterases should be given 15 to 30 minutes before removal of the endotracheal tube. Because at TOF count of 0.4, at least 15 minutes are needed to reach a TOF count of 0.9. That is when most of the muscle paralysis has been recovered. So at a TOF count of 0.4, generally patient can open eyes. TOF count of 0.6, patient will be able to protrude the tongue and all these, lift the hand, protrude the tongue, but there is an endotracheal tube present over there, so that that does not mean that your pharyngeal and the esophageal muscles have recovered. Okay, the tube is protecting the airway, so patient can lift hand and all. The muscle power recovery is there in the peripheral muscles, but does not mean your central muscles, your diaphragm, because the tube is in place. The tube is helping the patient breathe. Yeah, so a TOF ratio of 0.9, studies have shown that is when your pharyngeal, diaphragm and your esophageal muscle recovery is nearly 95%. But still residual paralysis has been seen even with a TOF ratio of 0.9. Now the type of neuromuscular drug used during the surgery, long versus intermediate acting drug. So the recovery depends on the anticholinesterase action and decrease in concentration of neuromuscular blocking drug at the junction. Okay, so the neuromuscular blocking drug at the junction will decrease only the duration of action of intermediate is shorter acting. So the intermediate acting have lesser blockade as compared to the long acting. So you can administer anticholinesterase because there is lesser number of the intermediate acting, lesser number of drugs occupying the receptors as compared to the long acting neuromuscular blocking drugs. Now your type and dose of anticholinesterase. Larger doses result in more rapid and complete reversal of blockade, but until the ceiling effect is reached. Reversal of blockade does not, between adults and children, same dose can be given, no dose adjustment is required. Duration of action is prolonged in older patients, that is, neuromuscular blocking drug duration of action is also prolonged in older patients. That is because of all the age related physiological and pharmacological factors. So since the neuromuscular blocking drug action is also prolonged, this action is also prolonged, hence there is a decreased risk of recurrization. Now your type of anesthesia used, volatile anesthetics intensify the action of your non-depolarizing muscle relaxants, and hence will interfere with antagonism, and hence any volatile anesthetic use should be stopped in advance. The mode of administration of the neuromuscular blocking drug. For infusion, generally cisatracurum is the drug of choice because of rapid clearance, and as such recovery will be quicker and you can administer the drug quicker, the reversal agent quicker. Acid-base status, respiratory acidosis, metabolic acidosis. The dose of neostigmine is nearly double to produce a comparable recovery. So respiratory acidosis and metabolic acidosis are two conditions where the neostigmine dose is double to produce a comparative recovery. So when you have 1 to 2 responses, this is important, 1 to 2 responses to a TOF ratio. Okay, this is during qualitative analysis. Okay, now we talk about qualitative analysis. That is qualitative. That is your peripheral nerve stimulator. Okay, peripheral nerve stimulator. Qualitative analysis. So when you have a TOF count of 1, it is an intense block. Do not reverse the patient. No reversal agent should be given. A TOF count of 2 to 3, right? A TOF count of 2 to 3, you can sorry, yeah, a TOF count of basically 2 to 4. You can 2 to 3. You can give neostigmin 70 microgram per kg, edrophonium 1.15 mg per kg, pyridostigmin 350 microgram per kg, and you have to wait for the TOF count to return to zero point 0.9 before extubation. Now, when your TOF ratio is here, you have to wait at least 15 to 30, at least 30 minutes before TOF ratio becomes 0.9. When your TOF ratio is more than is 0.4 and you see a fade, there's a fade in response. It's not a sustained response with the TOF ratio of 0.4. That's when you give neostigmin, moderate dose of neostigmin, 40 to 50 microgram per kg, edrophonium 0.5, pyridostigmin 200 microgram per kg, and you have to wait around 15 minutes before TOF ratio of 0.9 is reached. Now, when your TOF ratio is 0.4, you don't have a fade, you can give a low dose of neostigmin, which is 20 microgram per kg. I'm sorry. This is your 20 microgram per kg. That is no fade. Now with your qualitative, this is your qualitative. Now I'll talk about your quantitative. Quantitative analysis, that is your accelerometry. Okay. So when the TOF count is 1, no reversal agent should be given. Should not attempt to reverse the patient. TOF count is 2 to 3. This is a deep block, and you can again a higher dose 70 microgram per kg neostigmin, pyrido 350, and edrophonium 1 to 1.5 should be given. And once the TOF ratio is 0.9 on the axillomyogram, that's when you extubate the patient. A TOF count of 4 to 7, you can, a moderate dose is given, neostigmin 40 to 50, edrophonium 0.5, and pyridostigmin 200 microgram per kg. Again, extubate the patient and the TOF count is 0.9. When your TOF count is more than 0.7, you can give a small dose, that is 20 microgram per kg, or you can avoid the muscle relaxant. Now, some of the complications, if given when neuromuscular function has recovered completely, that is, there is no residual paralysis, it can lead to paradoxical muscle weakness. This is an important complication. Sensitivity of the upper airway muscles to an overabundance of acetylcholine. The reason for this paradoxical muscle weakness, especially in the diaphragm, is because of the sensitivity of the upper airway, because of there is excess of acetylcholine, so the upper airway muscles become sensitive, and this resulting in desensitization of the receptors. So the receptors, because of so much of acetylcholine, become desensitized and do not react to acetylcholine. This resulting in a depolarizing block or an opal channel blockade. It can cause nausea and vomiting against the muscarinic effect, stimulation of gastric fluid, counteracted by anticholinergic drugs. Your cardiovascular side effects, like I said, pronounced vagal bradycardia and bradyarrhythmias. In order to counteract these effects, atropine and glycopyrrolate are given. The parasympathetic control of the heart rate is less impaired with glycopyrrolate. So your decrease in the baroreflex sensitivity and heart rate variability is less seen with glycopyrrolate than with atropine. Hence, glycopyrrolate is better. Yeah. The onset of cholinergic effect of neostigmine corresponds with the that of glycopyrrolate, like I have been emphasizing. Bronchoconstriction by stimulation of muscarinic receptors, it can do bronchospasm. Now coming to, these are some of the newer, this is a newer reversal agent which has been approved in the UK. Okay, we do not have it here. So Sugammadex reversal occurs at all levels of neuromuscular blockage. So even your intense block, where there is no TOF, no tetanic stimulation, you can give Sugammadex. It is basically used for vecuronium, rocuronium reversal. Yeah. So Su refers to, I'm sorry, Su refers to sugar, and gamma dex refers to the structural molecule gamma cyclodextrin. So gamma dex is basically a gamma cyclodextrin. Okay, I'll show you the structure. It is a non-selective, it is a selective relaxin binding agent that is currently available for clinical use in Europe. It is a three-dimensional structure that resembles a hollow donut. It resembles a donut. See, it's like this. Okay, a truncated structure measuring a donut, a hollow donut. So this is your hollow with a hydrophobic cavity and a hydrophilic exterior. So this is your hydrophobic. This hydrophobic cavity, and this is your hydrophilic exterior. So this hydrophobic cavity is where it traps the vecuronium and rocuronium. So this is where it traps your non-depolarizing muscle relaxant. Okay. The mechanism of action: the hydrophobic, the high, sorry, the hydrophobic interaction traps the drug. Sorry guys, I'm having some problem. Yeah. So the hydrophobic action traps the drug like rocuronium in the cavity, resulting in a tight formation of a water-soluble guest-host complex in a ratio of 1:1. So it forms a water-soluble. It traps the drug in the donut hole, which is basically hydrophobic, and forms a water-soluble guest-host complex. It terminates the neuromuscular blocking drug action and restrains the drug in the extracellular fluid, where it cannot interact with nicotinic acetylcholine receptor. So basically, how it acts is, first it binds to the drug in the plasma, whatever drug is there in the plasma. Then as the plasma concentration of the drug decreases, of rocuronium and vecuronium diffuse away from the receptor and come into the plasma, where it is bound by this Sugammadex. So Sugammadex first binds to the molecule in the plasma. As the plasma concentration decreases, the drug diffuses away from the receptors, neuromuscular, the nicotinic receptors, and comes into the plasma, where it is bound by Sugammadex and eliminated by the kidneys. Now rocuronium is basically eliminated by the liver, but when bound to Sugammadex, it is eliminated by the kidneys. So goes for vecuronium. Okay, now this molecule is generally these cyclodextrins are basically 5, 6 and 6, 7, 8 cyclo oligosaccharides, and it is classified as alpha, beta, gamma cyclodextrin. This is a gamma cyclodextrin consisting of 8 oligosaccharides. So the The cavity size is generally 7.5 to 8.5 Armstrong. Okay, 7.5 to 8.5 Armstrong. But what happens is, so this is not sufficient. This size is not sufficient to accommodate rock uranium. So basically, 11 the size is made to 11 Armstrong by attaching these side chains, as you can see. So the size of the hollow cavity is increased to 11 Armstrongs by these side chains, which helps to accommodate rock uranium. So the dosage is 4 to 8 milligram per kg. Injection of 8 milligram per kg is given 3 minutes after administration of 0.6 milligram per kg of rock uranium. There is complete recovery of TOF ratio to 0.9 within 2 minutes. Due to hypersensitivity and allergic reactions, it has not yet been approved by the US Food and Drug Administration. Now, renal excretion is the primary route of elimination by forming for rock uranium, because it forms a complex with gamma dex. So, in patients with renal failure, hemodialysis has been shown to be an effective way of removing this complex. So doses, the maximum dose of Sugamadex with rock uranium, that is when you give the maximum dose of rock uranium 1.2 milligram per kg for rapid sequence intubation, it can be reversed with 16 mg per kg of Sugamadex. Now L-cysteine, it is not in use yet, it is still under trial in animal study trial. It is an endogenous amino acid that is often added to total TPN, total parenteral nutrition, to enhance the calcium and phosphate solubility. This is in basically bedridden patients, so debilitated patients. So it reverses the neuromuscular blocking action effects of gantacurin and other fumarates, basically fumarate neuromuscular blocking drugs. It's ultra short acting. So these gantacurin and the fumarates combine with L-cysteine and form less active, basically inactive degradation products. This occurs due to adduction of cysteine to the double bonds of the compound. So it's known as cysteine adduction. There's cysteine adduction happening to the double bonds of the compound, leading to inactive products. Okay, as doses as large as 10 to 50 milligram per kg is given. Has been tried in monkeys, anesthetized monkeys, 1 minute after neuromuscular blocking agent, and this abolished the block within 2 to 3 minutes. So 1 minute after giving a neuromuscular blocking drug, this agent was given, and within 2 to 3 minutes, blockade was reversed. So guys, but that the L-cysteine is still under trial. It is not in human use. It has been used only for animal trial studies have been done. So guys, this was on reversal agents today. I have spoken briefly. The reversal agent of choice is neostigmine, and to counteract the muscarinic effects like bradycardia, increased secretions, nausea, vomiting, urination, to counteract these muscarinic effects of this drug, glycopyrrolate anticholinergic is administered along with this. Now neostigmine is the anticholinesterase of choice. I'm sorry, the cholinesterase inhibitor of choice, because it is the duration of action is intermediate, unlike pyridostigmine, which is long acting and takes time for onset of action. Neostigmine onset of action is within 2 to 3 minutes. It forms covalent bonds with the enzyme and hence leads to degradation of the enzyme as well as inactivation, whereas edrophonium only leads to inactivation of the enzyme, and it is short acting because it diffuses away from the enzyme, because there is no degradation of the enzyme. Hence neostigmine is the drug of choice, and it should be administered only when the TOF ratio has returned to approximately 0.4 and when peripheral nerve stimulator is used, and a duration of 15 to 30 minutes should be given. 15 minutes should be given. That's when the TOF ratio returns to 0.9 before tracheal extubation. In an intense block, when there's no TOF ratio, reversal agent should never be given without, and hence reversal agent should not be given without neuromuscular monitoring ideally. So guys, this was my class on today. My next class will be on Thursday at 11:30 a.m. which will be intravenous agents. Okay, on Thursday 11:30 a.m. Guys, use my code use my code Sasha, like I told you previously, to get your 10% discount for your 12 and your 24-month subscription. So use my code SASHA and avail your 10% discount. Thank you guys. Have a good evening.